Subcommittee on Human Rights and the Law will come to order. Good morning, everyone. Good morning.
Good morning.
I first want to take a moment to thank the City of Decatur and Mayor Garrett for opening your hall to us and for all you do for the city and the state. Thank you, Mayor, for having us. We are here today to hear from doctors about how Georgia's abortion ban is impacting the health of women in our state. After the Supreme Court overturned Roe v. Wade, a Georgia law took effect banning abortion after just 6 weeks of pregnancy, at which point many women do not even know that they're pregnant. The New York Times described Georgia's abortion ban as, quote, one of the country's most restrictive laws. The Subcommittee on Human Rights has convened this hearing roughly 2 years after the reversal of Roe v. Wade to hear directly from Georgia doctors and health experts about the impact on women's health of Georgia's 6-week abortion ban. I want to thank our witnesses for taking the time to provide testimony today. You are all busy and hardworking healthcare professionals. We appreciate your contributions. I know this is a complex issue that evokes strong feelings across the state. That's why it's critical that the public hear directly from doctors about the consequences of Georgia's 6-week abortion ban. We often hear politicians and elected officials weighing in on this issue. But today we're going to hear from the healthcare professionals who treat women and support them through pregnancy every day. On that note, without further ado, I will now swear in our witnesses. I'll begin with introductions. Dr. Nisha Verma is an OB-GYN providing reproductive health care in Atlanta, Georgia, and an assistant professor of gynecology and obstetrics, specializing in complex family planning. She currently has a research grant to explore the impact of Georgia's 6-week abortion ban on individuals with high-risk pregnancies in the state of Georgia. Dr. Suchitra Chandrasekaran is an associate professor in gynecology and obstetrics and maternal fetal medicine specialist. She is also a member of the Society of Maternal Fetal Medicine Health Policy and Advocacy Committee and sits on the Maternal Morbidity and Mortality Committee for the state of Georgia. And Dr. Aiswara Panakam is an OB-GYN resident in Pittsburgh, Pennsylvania, who originally hails from Cumming, Georgia. Before beginning her residency, she obtained her undergraduate education at Johns Hopkins University, completed a Fulbright Fellowship, and graduated from Harvard Medical School. Before opening statements, we'll swear in the witnesses. So if you would all please rise and raise your right hand. Do you solemnly swear that the testimony you're about to give before the subcommittee is the truth, the whole truth, and nothing but the truth, so help you God?
Yes.
Let the record reflect that the witnesses have answered in the affirmative. You may take your seats. And we will now turn to the witnesses for opening statements, beginning with Dr. Verma, when you're ready.
Thank you, Senator Ossoff, and thank you all for being here today. My name is Dr. Nisha Verma. I'm a board-certified, fellowship-trained obstetrician and gynecologist providing full-spectrum reproductive health care. I'm a fellow with the American College of Obstetricians and Gynecologists, a nonpartisan, evidence-based professional organization representing over 60,000 OB-GYNs. I'm also a proud Southerner. I was born and raised in North Carolina. I currently provide care in Georgia, and I've lived in the Southeast for most of my life. After the Supreme Court's Dobbs decision, with Georgia enacting a law that bans most abortions in our state very early in pregnancy, I struggle every day to provide necessary life-saving medical care. I've seen young pregnant moms with worsening medical conditions and couples whose deeply desired pregnancies are in the process of miscarrying be turned away or forced to leave their communities to access needed health care. As a doctor, I have the immense privilege of sitting with patients and learning about their lives. For me, these patient stories are a powerful reminder that abortion is not an isolated political issue. And today I want to provide a glimpse of how abortion restrictions impact real people. Shortly after Georgia's ban went into effect, I saw a high schooler that I'll call V, who realized after missing her period that she might be pregnant. When she came to see me, she unfortunately was just a couple days past Georgia's arbitrary cutoff, which bans most abortions after just 2 weeks from the first missed period. I had to tell her that even though I have the skills to help her, I could no longer perform her abortion in our state. Unfortunately, V was unable to find the resources and support to leave Georgia for abortion care. Because of workforce shortages in rural Georgia where she lives, she also couldn't find a close by doctor that could care for her for many months. So even though V was forced to continue her pregnancy against her will, she couldn't access the prenatal care she needed to keep herself and her pregnancy healthy. After delivering her baby, V struggled with postpartum depression and had to move out of her home, drop out of school, and work a minimum wage job to try to make ends meet. She told me that she loves her son, but this is not the life that she wanted or planned for herself. V's story, while heartbreaking, is not unique. Over the past couple years, I've conducted a research study to learn about the experiences of patients with high-risk pregnancies in Georgia who are attempting to access abortion care. Through this work, I've heard women describe again and again how Georgia's abortion restrictions exacerbate their suffering in already devastating situations and leave them feeling betrayed by a government and a healthcare system that is supposed to protect them. One participant, M, described breaking her water at 17 weeks when she had no chance of her baby ever developing lungs that would allow it to live outside of her. She went to the hospital, but learned her doctors couldn't help her until she started bleeding or developed an infection. M told me that to be denied the basic medical care I needed, to be told that I must first be at risk of dying, to be forced to relive losing my baby every day for 5 days because of Georgia's law, the trauma of that on top of my loss is devastating. Another participant, A, discussed how Georgia's ban rushed her into making a decision instead of allowing her the time to get genetic testing on her pregnancy. She shared that her older son was diagnosed with a rare genetic condition that destroyed his lungs when he was just a few years old. Now, instead of starting middle school with his peers, he is admitted to the hospital ICU, and doctors have told A that he likely has less than a year to live. A described the pain of seeing her son suffer, and when she found herself pregnant again, she knew that she could not have another child affected by the same genetic condition. However, because this condition does not qualify for abortion care under Georgia's very narrow exceptions, and A could not risk leaving her son in the ICU to travel out of state later in pregnancy, she made the decision to get an abortion prior to Georgia's 6-week cutoff before testing on the pregnancy was possible. It is clear that women who need medical care are suffering because of Georgia's abortion restrictions. We also know that these restrictions are not based in data or science. In fact, in 2022, over 75 major professional societies representing the overwhelming consensus of the science-based medical community came together to reaffirm that abortion is safe, essential healthcare. To make matters worse, doctors, overwhelmed by laws that threaten to make us criminals for providing evidence-based, life-saving care to our patients, are leaving their states. In Georgia, where already over 50% of counties have no OB-GYNs, where we have one of the highest maternal mortality rates in the country, and where women like my patient V struggle to access prenatal care, these worsening workforce shortages are devastating for all aspects of reproductive health care. I understand that abortion care can be a complicated issue for many people, just like so many aspects of healthcare and life can be. I also know that abortion is necessary, compassionate, essential healthcare, and that patients are capable of making complex, thoughtful decisions about their health and lives. No law should prevent them from doing so. Thank you for having me today, and I look forward to questions.
Thank you so much, Dr. Verma. We'll now turn to Dr. Chandrasekaran.
Thank you. Good morning, Senator Ossoff and members of the subcommittee. My name is Dr. Suchitra Chandrasekaran. I am a board certified and fellowship trained maternal fetal medicine or MFM specialist. And I am here today as a member of the Society of Maternal Fetal Medicine to describe the harmful effect restrictions on reproductive health have on their patients, their families, and the clinicians that care for them. As an MFM, I actually provide care for pregnant persons who experience complications that make their pregnancies high risk. I proudly take care of pregnancies affected by maternal health issues. They can range from hypertension, diabetes, to cancer, and complex life-threatening heart disease. Throughout this care, I perform ultrasound and provide genetic testing to assess fetal well-being. As an MFM practicing in Georgia, what I want to tell this audience is that the Georgia abortion ban limits the ability of myself and my colleagues to provide evidence-based care and counseling, and significantly puts the well-being and lives of our patients at unnecessary risk. Having previously practiced in states where I could provide full-scope evidence-based care and counseling, I'm horrified and deeply saddened by the situation and the lack of choices our patients are given. While I live and see these stories daily, I'm going to bring up a few of them here. And I want to say that while I am using the word stories in this testimony for my patients, these are not stories. These are real life nightmares and tragedies. So previously, I practiced in the state of Washington. And during one of those call shifts, I received a call about an individual in her second trimester with a pre-existing heart condition. This is actually pretty common in pregnancy because pregnancy is a time where your heart actually really changes, and that's often when pre-existing conditions might be diagnosed. This patient had inadequate healthcare coverage, and so this was the first time her condition was coming up. This was her first pregnancy, and this was her dream to be a mother, to go through a pregnancy in a normal fashion. But now she was facing her nightmare with a life-threatening heart condition, scared for her health and her baby's. Because of Washington State's protective abortion laws, I was able to offer abortion as an option, as a choice for her. After many days of a lot of thought, weighing her risks and processes, she made the gut-wrenching and challenging decision to terminate that pregnancy, to focus on taking care of her heart so that she could potentially do this again. Subsequently, this patient did have the opportunity to get her heart condition fixed and had her next pregnancy. And I had the personal joy and privilege of delivering that baby in her next pregnancy. I had held this woman's dead fetus wrapped in a knitted blanket in her first pregnancy, and I held her beautiful baby boy in her second pregnancy and cried tears of joy with her. Fast forward 7 years, right? The dreaded morning of June 24th, 2022, when the United States Supreme Court released its decision on Dobbs. Right as we heard the news, my sonographer brought my next ultrasound for me to review. This ultrasound was for a woman who had not had access to insurance or care until the early second trimester. Access to healthcare is a major issue here in Georgia, which is burdened by the presence of many obstetric deserts or regions with limited medical access to prenatal, perinatal care. This woman was excited and eager to see her baby. It's her first ultrasound. I, however, saw a fetus with a significant cardiac defect. Although this baby would be born alive, meaning that the case did not fit within Georgia's exception for medically futile pregnancies, the prognosis and quality of life after birth would be extremely limited. Even after multiple surgeries, the long-term outlook for this kind of a heart defect was questionable. 10 minutes ago, before the scan, I would have counseled her on all of the risks and the termination option of this pregnancy. 10 minutes later, I walked into her room, shell-shocked at how the only practice and counseling methods I had known for 15 plus years was now impacted. And I spoke to her about my concerns for this fetus and what the cardiac defect would mean for the infant when it was born. As a doctor, my job is to support whatever decision the person wants to make, whether it's to continue a challenging pregnancy or whether to terminate it. As a doctor, my job is to inform of all the risks and outcomes. But now, as a doctor, my ability to counsel and provide all the opportunities was limited. My patient was in tears, knowing the law had just gone into effect, and I too only had tears to share with her at that moment, and the nightmare had begun. Even before the Dobbs decision, the high maternal morbidity and mortality rates affecting the state of Georgia are well known. One of the largest drivers of this rate is maternal cardiac disease. Yet, Georgia's ban forces women with very high-risk maternal cardiac conditions to carry their pregnancies, sometimes regardless of the dangers to a mother's health. For example, I had a patient with a disease process called lupus. In its severe form, it can significantly affect a pregnancy and threaten maternal and fetal health, including kidney, heart damage, or a very preterm delivery. This patient had a severe version with significant heart disease. She was in the late first trimester when she found out about her pregnancy. She was scared, knowing her very serious risk of becoming sick and facing health issues. But now, even though she was only in the late first trimester, I couldn't provide her all the options. I couldn't provide her that full spectrum reproductive health care. I could talk about it, but I couldn't realistically help provide it. My hands were tied as a provider. She didn't have the resources to obtain care anywhere else. And in a state where maternal morbidity and mortality are extremely high with cardiac risk factors, this abortion ban can only worsen this issue. In a state where maternal mental health is another key contributor to morbidity and mortality, the trauma of being stripped of autonomy to make critical personal health decisions is real and long-lasting. It's not just the now we have affected. We have detrimentally impacted long-term maternal morbidity and mortality in a state that already has high rates. I am committed to remaining in Georgia and providing the best possible care for my patients in this challenging environment. I have provided stories above. I have demonstrated what success can look like when full scope care can be provided. I have shown the aftermath of not being able to provide that care. High-risk pregnancies are unexpected, life-threatening, emotionally traumatizing, and life-changing for all involved. The current abortion ban in Georgia limits our ability to provide the compassionate and full-spectrum reproductive counseling and choices to our patients, and will only continue to worsen the overall future health of pregnant persons in Georgia. Thank you for having me today.
Thank you, Dr. Chandrasekaran. Dr. Panikam, please.
Good morning, Senator Ossoff and distinguished members of the Human Rights and the Law Judiciary Subcommittee. My name is Dr. Aishwarya Panikam, and I use she, her pronouns. I am a recent graduate of Harvard Medical School and a current resident physician in obstetrics and gynecology at an academic medical center in Pennsylvania. I'm testifying today in my personal capacity, and thank you for this opportunity. I grew up in Georgia, and I too am a proud Southerner. After spending the past decade of my life studying in other parts of the country, I was very eager to return home to my friends and family to complete my medical training. Yet I'm here today to explain why I chose not to pursue OB-GYN residency in the South. I was halfway through medical school when the Dobbs decision ended the constitutional right to abortion. Immediately, trigger bans were initiated across the country, including here in Georgia. Over the next 2 years, every single Southern state instituted either a total ban or a prohibitively early gestational age ban on abortion. When it came time to apply for residency, many applicants into OB-GYN, including myself, prioritized programs that offered training in full spectrum reproductive care, which includes abortion and miscarriage management. It was a bitter day when I realized I wouldn't be able to receive this training to the same extent in any Southern state, including Georgia. Ultimately, I prioritized programs in other regions of the country. To contextualize why I made this choice, I would like to share a few key facts. First, abortion is common. Prior to the Dobbs decision, 1 in 4 women of reproductive age in the United States was predicted to have an abortion by age 45. Second, abortion is safe. It is one of the safest procedures that a person can undergo. For abortion to remain accessible and safe, reproductive health physicians like myself must receive this essential training. The need for comprehensive training is also recognized by accrediting bodies. The Accreditation Council on Graduate Medical Education, or ACGME, requires that all OB-GYN residency programs provide their residents with comprehensive clinical experience in abortion. However, since the Dobbs decision, an OB-GYN in the South now faces a myriad of uncertainties and often has more questions than answers. Will I have sufficient case volume? Will I learn to manage complex cases? Would I be able to confidently perform this procedure on my own? Residency is a difficult process in and of itself. Additional roadblocks to obtaining necessary training will continue to dissuade talented physicians from practicing in the South and in other states with abortion restrictions. It is important to recognize that abortion training gives OB-GYNs an additional skill set that they can apply to diverse scenarios, including medical emergencies. Even if an OB-GYN does not regularly perform abortions in their clinical practice after training, if they are trained in procedural abortion, they will be better equipped to manage a variety of different conditions. This includes miscarriage, hemorrhage, infection, and many more. Training in abortion makes for a capable OB-GYN. Georgia must prioritize the development of OB-GYNs because its maternal health outcomes are among the worst in this country. Half of Georgia's counties lack a single OB-GYN, leaving 1 in 3 women without access to essential healthcare. The sad truth is that Georgia desperately needs more OB-GYNs, but it is failing to attract them. In 2022 to 2023, applications to OB-GYN residency in restricted states decreased by 5.6%. A recent survey of medical students applying into OB-GYN sheds light on a major reason. 73% of survey respondents reported that the Dobbs decision affected which programs they applied to. And this is the case for myself as well. I am deeply concerned about the dangers that Georgia's 6-week abortion ban creates for women. As a medical student in Massachusetts, I helped care for a Georgia woman whose fetus was diagnosed with severe genetic anomalies. Even though it was well understood that her fetus would die either in utero or soon after delivery, she was unable to receive an abortion because her fetus still had a heartbeat. It took her several days to arrange childcare for her young daughter and for her and her husband to come up to Massachusetts, get a hotel room, and get an appointment at the clinic that we were at. When she arrived to our clinic, her fetus had already passed and had been dead for several days. She was admitted to the ICU for a life-threatening clotting disorder called disseminated intravascular coagulation, as well as massive immune dysregulation in the form of sepsis. Georgia's abortion ban jeopardized her life by delaying her access to care. She survived. Others have not. This case reaffirmed my commitment to train in a place where abortions can be accessed by women who need them. I speak on behalf of the tens of thousands of medical students and physicians who are currently in the training pipeline and who will make up the future healthcare workforce of this country. States that severely restrict abortion access will struggle to attract and retain OB-GYN physicians. This will cause shortages to their physician workforce. I made the difficult decision to not return home for my medical training. A lot of my peers have done the same. With the support of our lawmakers, we can expand abortion access, which in turn will help reverse this exodus of students, doctors, and health professionals leaving restricted states. Thank you for having me today, and I look forward to your questions.
Thank you, Dr. Panicam. And thank you all for your opening statements. I'd like to begin with a yes or no question for all of you. In your opinion, does Georgia's 6-week abortion ban endanger the lives of pregnant women in Georgia? Dr. Verma?
Yes.
Dr. Chandrasekaran?
Yes.
Dr. Panicam?
Yes.
Dr. Verma, Georgia's abortion ban contains an exception for medical emergencies, which the law defines as, quote, a condition where an abortion is necessary in order to prevent the death of a pregnant woman or a substantial and irreversible physical impairment of a major bodily function of the pregnant woman. Given that exception, why do you believe Georgia's law nevertheless endangers the lives of pregnant women in our state?
For that question, as doctors, we train for years and years and years to be able to sit in front of the patient in front of us and help them and their families make these complex, individualized decisions. Medicine is incredibly complicated. That's why we train for so long. There's not a line in the sand where someone goes from being totally fine to acutely dying. A lot of times it is a continuum. And doctors, because of this law in Georgia, are forced to question, when can I intervene? How sick is sick enough? How much bleeding is too much bleeding? That delays care, that forces patients to get sicker. Georgia's exceptions in our abortion ban are incredibly extreme. And we've seen in the data as well that even when these types of exceptions exist, people with high risk pregnancies are still denied care and have a harder time getting the care that they need. Some are forced to continue very high risk pregnancies. Some are forced to leave their communities, and all of that leads to people getting sicker and sicker.
Thank you, Dr. Verma. Dr. Chandrasekaran, can you weigh in here where the so-called exception in the law in cases where a pregnant woman's health is severely at risk, but perhaps not yet meeting this restrictive emergency standard?
I think this goes to the concept that biology is gray. Biology is not black and white. It's not a mathematical equation. If our bodies were mathematical equations, we could be running this very differently. And when biology is gray, pregnancy, which is now putting two lives, a mom and a child, and making them interact with each other in a relationship of sorts, is extremely gray. So when we say words such as irreversible or futile, oftentimes by the time you've hit irreversible and futile, mom's life is already at significant risk. You've taken away her choice and capacity to make a decision to potentially avoid hitting irreversible and futile. And I think that's the challenge with the current abortion ban. And that's what directly affects overall maternal health, mental and physical.
Thank you, Dr. Chandrasekaran. And on that point, with respect to, quote, medically futile pregnancy, and that's the term in Georgia's extreme 6-week abortion ban. The quote from the statute is, "In reasonable medical judgment, an unborn child has a profound and irremediable congenital or chromosomal abnormality that is incompatible with sustaining life after birth." Does this exception meaningfully allow doctors in Georgia to provide adequate care when a fetus has been diagnosed with a serious defect?
Unfortunately not, because again, fetal diagnostics is also a gray territory. When we see a heart defect, we can say what we overall think the prognosis might be. But when we use words, again, such as futile, irreversible, irrevocably, what does that mean? How are we protected under that? How do you define that? Biology changes. What might feel irrevocable to somebody may not be to someone else. And that becomes a very personal decision between a physician and the patient on what are they looking at? What are the outcomes for this fetus looking like? And so unfortunately, when we use those words, it doesn't provide capacity to help the majority of our situations. Now, the extreme situations are an exception, but the majority of our situations fall into, we think this would be the prognosis. This is the likely situation to happen. This is likely the outcome. That doesn't get covered.
Thank you. Dr. Verma, Georgia's law also contains a so-called exception for, quote, removing a dead unborn child caused by spontaneous abortion, end quote. Does this exception meaningfully empower Georgia physicians to provide medically necessary care for miscarrying patients?
It's a great question. I have absolutely seen situations where patients in the process of miscarrying are turned away or delayed from getting the care that they need in Georgia. Again, all of this is really complicated. I think that's what we keep going back to. Medicine is incredibly complicated. So I've had situations where a patient presents to the hospital, their cervix is opening, they're bleeding, they may have broken their water, but that pregnancy still has cardiac activity or a heartbeat. And there's a lot of uncertainty about whether doctors can act in that situation, when in that scenario they can act. I've had patients like some that I shared today in my testimony that are turned away, and even though they're in the process of miscarrying, because that cardiac activity is still present, and they're told you have to start bleeding more, you have to get sicker, you have to develop an infection. And so often when people are miscarrying, that's a process, and we are having to wait until later in that process, until they get sicker, until they have more bleeding, until they have an infection, until we can intervene, instead of working with that patient to figure out what their needs and desires are, and when in the process it works for them for that treatment to happen.
Thank you, Dr. Verma. Dr. Chandrasekaran, miscarriage management and Georgia's 6-week abortion ban. What's been your assessment and experience?
I think I can only echo what Dr. Verma has said here. Again, the term miscarriage encompasses a spectrum of situations. And so it can start with bleeding. It can start with continuing to have a heartbeat. It can start with water breaking at a time in your, mid-second trimester, where now the fetus, even if it were born, what would that look like in terms of lung development? And then comes the question, a common discussion we have, how much bleeding is too much bleeding? Are they stable? The other key thing to remember with, I always say this with pregnancy, is what seems normal 2 minutes before can change in pregnancy very fast. And so when we have these restrictions and you're told you have to wait until a tipping point, oftentimes once you've hit that tipping point, you've hit a point of severe discomfort, damage, and physical damage to mom. The procedures become more complicated to do at that time. And now you have extra care issues and extra health issues going on. So I think I can only repeat, it's complicated. It's not a black and white issue. And when we've taken away that discussion capacity between the physician and the patient to have that choice on what is best for the patient in that situation, by putting words that have to define that situation, it is inhibiting and limiting capacity for care.
Thank you, Dr. Verma. In your testimony, you stated that Georgia's law threatens to make criminals out of doctors for providing necessary life-saving care. Do doctors in Georgia fear the threat of criminal prosecution for providing necessary reproductive health care to pregnant women?
Absolutely. So we are practicing, and again, we've said again and again, medicine is incredibly complex. We are trying to navigate this complexity under a law that says if a lawmaker or an attorney general decides we have made the wrong decision, we acted too soon, the consequences are criminal prosecution, or having your license removed, your livelihood threatened. And that's creating a huge chilling effect for doctors across the state. And so again, I've seen doctors that are limiting their scope of practice, or saying, I'm just not going to take care of pregnant people anymore. I'm going to only do GYN care, because they're so afraid of those very extreme consequences that makes the care deserts even larger in our state. I've talked to physicians that are leaving the state completely because they're so afraid. And then I've seen doctors that are not able to take care of patients, that have to transfer them out of state or transfer them to another hospital, and those patients get sicker and sicker. And so when we're trying to figure out, again, where in that how sick is sick enough we can intervene, we know what the right thing to do is medically, right? That's what we train for all of these years, to work with our patients and make these medical decisions with our patients, with their families. That's not the question. It is, what is this law that actually doesn't make any sense, that wasn't written by medical people? When does the law say I can intervene? And none of us know the answer to that. And so navigating this environment is incredibly scary and confusing.
Thank you, Dr. Verma. Dr. Chandrasekaran, you testified that you had a patient with severe lupus, which could have had significant impacts on maternal and fetal health. Can you explain in more detail what kinds of complications this patient risked as a result of being forced to continue her pregnancy with severe lupus?
Yeah. So again, biology is complex, and lupus is a process where for some reason your body thinks its own cells are not its own and seems to want to attack it. Those are called autoimmune diseases. And so when you're undergoing a pregnancy, which has its own physiological changes to your body, Sometimes the body can turn against its own organs and really important organs like the heart and the kidneys and the lungs. And when that happens to mom, obviously that's going to put mom's life at significant risk. And then if mom's life is at risk, oftentimes that means we need to do a delivery because the pregnancy is adding to risk. And that can mean delivery of a baby at a very scary gestational age where the baby's life is at significant risk because baby isn't developed enough. And so these are very real situations that families can face, leading to kind of long-term consequences for all the caretakers involved in that situation.
And as you know, as we've discussed, Georgia's law includes an exception for circumstances where termination is necessary to prevent a patient's death or, quote, substantial and irreversible physical impairment of a major bodily function. Yet you were unable in that case to offer termination as an option to your patient with a condition that, as you just described to us, created a risk of severe health complications. Why was the exception insufficient in this case? And how does the extremely narrow scope of this exception force doctors to put women in a position where they may continue to bleed, continue to be in pain, continue to take on greater and greater risk of irreversible harm, but doctors are unable to help?
The words again we used are substantial and irreversible, right? So I've taken care of many lupus patients now in my 15 plus years of practice. Some of them have severe issues. Some of them may not. Severity ranges on a scale. So when we say substantial and irreversible, I'm going to go back to the question, what does substantial mean? And this is where that gray territory comes. We know kind of what substantial means. I can talk to a patient and say, look, your chance of having cardiac failure might be this much. Your chance of having renal damage might be this much. But what defines substantial in terms of the law, and also what is substantial to each individual person in terms of the damage I'm giving them? I never have a crystal ball. If I had a crystal ball, I could tell you exactly what's going to happen. We don't in medicine, and especially in a field like OB, where you're dealing with two basically living organisms working kind of symbiotically with each other. And so when we use those words, it really limits that scope to feel safe in knowing what defines substantial, when that can vary in and of itself.
You described a patient whose fetus had a severe congenital heart abnormality and might either pass away in utero or survive and need extensive medical intervention with highly uncertain prospects for survival. The patient did not have the choice to terminate the pregnancy under Georgia's law. Why wouldn't that fall within Georgia's exception for a medically futile pregnancy? And if the fetus survived past birth, perhaps requiring intensive neonatal care, perhaps in immense pain, what would that baby's quality of life look like?
So again, the law puts the word futile. And so it is hard to predict that futility. Sometimes, yes, these babies can pass away in utero. Sometimes they can pass away right after birth. And sometimes they might do okay with a surgery or so in terms of living. But then that could mean, are they actually ever able to come home? Do they need to stay in an ICU the whole time? How are they recovering post-surgery? Some of these babies can stay in a hospital for even a year up to post-birth, just undergoing surgeries and undergoing care. So what does that put upon that life, that child, that family? That again is not covered in that medically futile. If you ask medically futile, some of us can be at institutions where you can define certain diagnoses that, yes, this is 100% medically futile. Again, 99% of what we do, we can't predict that word medically futile, but we know that the risks are extremely high.
This conversation has been focused on legal terminology, complex medical dynamics. Your patients are human beings with immensely powerful emotions surrounding their pregnancy and their health. What's it like as a doctor who cares about them to look into your patient's eyes who are experiencing a health crisis, who have learned that their fetus may have a severe health complication, and not have a choice or be able to offer them a choice in those extremely difficult situations? What are those conversations like now?
It's horrific. It's horrific. It's awful. It's almost degrading as a physician to not be able to do what you feel you need to do, and you're watching for what's protecting you in terms of a law. We will always do the best for our patients. I can say that. As a physician, we will always do the best for our patients. We will always have open discussions. But to practice in a situation with an umbrella above you that is limiting those discussions and having you also carry some of that emotional trauma and burden with your patient as you both are trying to navigate this with their families is unfortunately a very horrific situation in the state, and one that I agree with Dr. Verma is potentially going to drive away good physicians from our state.
And we'll explore that dynamic more soon with Dr. Panicam. But Dr. Verma, you stated that you see young mothers who have worsening medical conditions that make their pregnancies high risk or who are miscarrying, being turned away by doctors. And I think it's critically important that the public understand that miscarrying women are being turned away by their doctors in this state right now because of this extreme abortion ban, or forced to leave their communities in order to access care. We heard a story recently about a pregnant woman who had to travel to Massachusetts, and the fetus died in utero on the way, putting her at extreme risk upon her arrival out of state. Why are doctors in Georgia, Dr. Verma, turning away pregnant women in these circumstances?
I think it goes back to how confusing these laws are. There is no way to create a law that takes every individual, every medical situation, every family into account. And so you can put into a law, I've heard lawmakers who created these laws often say, well, there are exceptions. And so people that need care will get care. One, I take care of patients who need abortion care for many different reasons. I would say the vast majority of them are excluded from getting care under this law. And the exceptions don't solve that problem. They're incredibly confusing. They don't make sense to the practice of medicine. We talked about how miscarriage is often a process. There could be a time in that process when there's still a heartbeat or cardiac activity, and doctors don't know if they can intervene. When we talk about medically futile pregnancy, there's no consideration of quality of life, right? So the patient I discussed, that wouldn't qualify under Georgia's law because her baby once born could potentially live for years, but she would have to watch that baby suffer and die if the baby was affected with the same genetic condition. And so the quality is not taken into account at all. When we talk about the medical emergency exception, it is incredibly extreme, and there are many people with high-risk pregnancies that that aren't yet in that category of being, immediately at risk of death. One example I'll bring up, I had a patient with pulmonary hypertension, which is a condition where your lungs don't work correctly. Your risk of death, if you continue the pregnancy, is as high as 50%. When we see that patient at, for example, 6 or 7 or 8 weeks, she often hasn't gotten a chance to get very sick yet. Can we provide an abortion then? Or do we have to turn her away and say, come back when you get sicker, when your lungs aren't working anymore, when you have that 50, when you are actually at risk of immediate death? The right thing to do medically, right, is to offer that patient the options of termination or continuing the pregnancy when we see her at 6 weeks. But under the law, it's often unclear if we can do that. The last thing I'll just mention, I do think it's really important to recognize how this law takes these really important risk assessments away from people. So all of us take care of patients with very high risk pregnancies who choose to continue those pregnancies. And our job is to support them and optimize their health and the health of their pregnancies. But that's a decision that a person should be able to make, right? And we also have patients who say that risk of continuing that pregnancy is too high. I cannot risk dying and not be around for my existing children and my family. And that's also something that that person, not the state, should be able to choose to do. And so it's not that people can't continue risky pregnancies, but that is a decision that people should be able to make.
You mentioned that many patients who have been denied care have expressed a sense of betrayal to you. Can you elaborate on why patients might feel betrayed in those circumstances?
Absolutely. I think when people go to the doctor, they expect to be able to get compassionate, evidence-based medical care and to be told you can't get the same care that someone could get, for example, in Massachusetts, where I previously practiced, or in Delaware. You can't get that care here, not because it isn't evidence-based, not because I don't have the skills to do it, but because our lawmakers have decided you don't deserve that care. You can't get that care here. That is a huge sense of betrayal, right? I feel betrayed not being able to provide the care. Patients feel betrayed. We've created an environment in this country where your access to evidence-based care depends on your zip code and your resources and whether you can get out of state.
Thank you, Dr. Verma. Dr. Panicam, you described a case, we just referred to it again, that you witnessed at a clinic in Massachusetts where a Georgia woman traveled to terminate a pregnancy after finding out her fetus had been diagnosed with severe abnormalities. She wasn't able to terminate the pregnancy in Georgia, had to travel to Massachusetts instead. And by the time she arrived in Massachusetts, her fetus had been dead for several days. Why wasn't this patient able to terminate her pregnancy in Georgia under the exception for a medically futile pregnancy in the Georgia law?
So although this patient had a fetus with severe genetic anomalies, and it was well understood by all providers that the fetus would die in utero or soon thereafter, she was not able to access an abortion because her baby still had a heartbeat. And that is the reason why she had to arrange alternate forms of clinical care and why she had to travel out of state. And ultimately, that delayed her care by several days. And in that time period, her pregnancy had deteriorated and she didn't even realize it until she ended up becoming very sick.
And what risks was she then faced with after the demise of the fetus in utero?
So a demised fetus in utero increases the risk of several alarming pregnancy complications. One is hemorrhage, so the risk of excessive bleeding. The second is infection, which is what happened to her. She had an uncontrolled infection because we were not able to evacuate the uterus and take out the source of her infection in a timely fashion. And as a result of that, she developed a systemic infection that almost cost her her life.
As a physician and as a Georgian, how did it make you feel to see a patient who was septic, whose life was now at risk because she'd been unable to access evidence-based care in her own state?
It was really demoralizing. She was the first patient that I saw as a medical student from Georgia, and she suffered the worst consequence out of all the patients that I had taken care of in that clinic. That patient and many others like her are the reason why I decided not to come back to Georgia for my medical training, because I want to practice and I want to learn in a state where I can offer people the full spectrum of options and help them achieve the highest standard of health possible for them. I don't want my hands to be tied by a law, by legislators, by people who have very little understanding of medicine. And because of that, have my patients suffer as a result.
And just to be clear, sepsis after demise of the fetus in utero, this woman could have died, correct?
Absolutely. Sepsis is a leading cause of death in the United States. People often die from extremely low blood pressures, which we call septic shock, or organ failure. And in her case, she was able to bounce back, but not everyone is so fortunate.
Did Georgia's 6-week abortion ban put your patient's life at risk?
Absolutely. She wanted an abortion. She was not able to receive it in time. And as a result, her health deteriorated and she could have died.
You mentioned that you'd wanted to practice in your home state. And as we heard earlier, you may have mentioned it, perhaps it was Dr. Verma. Half of Georgia counties have no OB-GYN. We heard Dr. Verma's story about a patient in rural Georgia who, being unable to access an abortion, was then marooned without access to prenatal care. That increases risks for pregnant women. You wanted to come practice where you were from, but you chose not to because of our state's abortion ban. How did it make you feel to be unable to choose to come and practice medicine in your home state where we have a dire need for professionals with your skills?
I'm a good example of someone who wants to stay in Georgia. This is my community. The people I love are here. And I always envisioned a life here taking care of people. But that vision is not superseded by my need to do the right thing for my patients and my need to develop a skill set where I can respond effectively to medical emergencies, where I can appropriately advise and counsel my patients on the next step in their pregnancy and in their care. And unlike my colleagues, I'm still very early in my training. And so I speak from a place of potential. What is my potential to respond in the scenario? What is my potential to take care of people down the road? I make my decisions based off of who I want to be in a few years, in a decade, in a lifetime of service. And so at this point, that is that person I want to become requires training outside of a restricted state.
And how did seeing this patient who had to travel from Georgia to Massachusetts, is septic, whose life's at risk because of Georgia's abortion ban, how did that influence your decision not to come home and practice OB-GYN medicine in Georgia?
So the providers at the clinic I was working at knew how to respond to the scenario. They were extremely skilled in both the surgical management of her abortion, but also, taking care of her when she was admitted to the ICU. And I think we will see that more and more OB-GYNs are finishing their training in restricted states without a comfort level in offering or providing abortions. And that is due to a lack of exposure and training within their residency programs. I think that the patient I saw is one of many people who will not access this care because it is no longer legal where they come from. But in turn, for each of these patients, I think we will see many doctors who are not able to offer that care because they were not trained in it, or maybe they had some exposure, but that's not something that they feel comfortable doing independently without supervision.
Thank you, Dr. Panikam. Dr. Chandrasekaran, as you know, Georgia has extraordinarily high rates of maternal morbidity and mortality, meaning women in Georgia have high rates of health complications and death related to pregnancy and childbirth. Why are women in Georgia at such high risk of adverse outcomes from pregnancy? And how do you expect Georgia's 6-week ban to affect maternal mortality and morbidity in Georgia?
Georgia's maternal morbidity and mortality rate is complicated and it's layered, but many things contribute to it. I would say from kind of starting at a large eagle's eye view, access is a big issue. We've brought it up over and over again. So 6 weeks, to give context, is a time where many women don't even realize they're pregnant yet. Symptoms are barely starting at that time. So by the time they've realized they're pregnant and now potentially found a physician who can help them due to access, we're delaying care. to be able to intervene or make decisions. So access is probably one of the big reasons for maternal morbidity and mortality. Along with access then comes ability to give that care. So once access is gone, care isn't able to be given on time. That's also contributing to our issues with maternal morbidity and mortality. And then when care is not given on time, that's affecting overall health at a very granular level. So increased rates of diabetes, obesity, hypertension, all these cardiometabolic processes that contribute to pregnancy. So it's a tiered model of what's causing that risk. And the abortion ban is only going to feed into all levels of that model.
Dr. Verma, how do you expect Georgia's 6-week abortion ban to affect maternal morbidity and mortality for pregnant women in Georgia?
Expected to worsen maternal morbidity and mortality in a state where we are already facing these terrible rates, terrible outcomes for pregnant patients. We've seen in the data that states that have abortion restrictions also tend to be the states that have worse maternal mortality and morbidity rates. And again, this is complex. It is very complex, and there are multiple things that play into that, but having that limited access to care, whether it's abortion care or prenatal care, definitely contributes to worsening outcomes for our pregnant people.
Dr. Verma, in your opening remarks, you described a young patient who was compelled by Georgia's law to continue an unwanted pregnancy, but was unable to access prenatal care while she was pregnant because she lived in a part of a state without sufficient doctors, without sufficient clinics and expertise. What are the risks to pregnant women in Georgia who are unable to access prenatal care?
There are many risks to not being able to access prenatal care. Pregnancy is a time where, for many women, it is the highest risk thing that they are going to do. There are multiple complications that can come up. There are multiple issues that can come up that make that pregnancy higher risk for the patient, that for the pregnancy itself. And so prenatal care is incredibly important. This patient had Medicaid, so she had insurance, she had government insurance, and there was no one in her part of the state close by that she could get to easily as a teenager who took Medicaid. That is a huge shame, right? She had insurance from the government and couldn't get prenatal care when she was forced to continue her pregnancy. I think that's also part of what all of that combined is also contributed to her developing postpartum depression. We know that mental health conditions are one of the leading causes of maternal morbidity and mortality in our state and in the country. Mental health conditions are specifically excluded from Georgia's medical emergency exception. So Georgia as a state has decided mental health is it's not good enough to count for an exception. So if a patient is experiencing severe depression, is at risk of suicide, that does not count as a example of when we can provide care. And so this patient, after this whole experience, then experienced postpartum depression that put her life and her health and the health of her baby at risk as well. And this isn't unique, right? We're seeing this happen again and again and again.
Thank you, Dr. Verma. Dr. Panicam, did I hear you correctly earlier that OB-GYN residents in states like Georgia with extreme abortion bans often have to travel out of state to meet their own educational requirements?
That's correct, Senator. OB-GYN residents are caught in a really awkward situation where they need to receive this essential training, but they're not legally allowed to do it in the location in which they are training. This often necessitates them applying to away rotations in other states. This is a very onerous process. You have to do licensing again. It's expensive. You have to find alternate housing. If you have children, you have to find childcare and leave behind your family for several weeks to months at a time. And even if you can do all of that, there's a good chance you will be denied because there are not enough training spots in other states. The system only has so many slots and right now cannot accommodate people coming from out of state across the board. So this is going to limit many people's ability to access that training. Not everyone can travel out of state, and not everyone will be granted the opportunity. They will not even be granted a slot in order to do that. So it will restrict the training of many physicians in this country.
I would note, Dr. Panicam, applications for OB-GYN residency slots in Georgia decreased by almost 10% in the 2023 to 2024 application cycle. Do you believe that your peers are being deterred from applying for residency in states like Georgia because they're unable to access the training they need? They may be unable to provide the care their patients need. They may face criminal prosecution.
Absolutely. As I said earlier, abortion is common. So training in abortion is a commonly sought out experience by people going into reproductive health care. And our training in a variety of different procedures will determine what we can do as independently practicing physicians. So we don't want to artificially restrict our skill set, our medical knowledge by legal restrictions. We want to understand what the entire scope of evidence-based medicine is in OB-GYN. And at this point, just entering the field, it seems like a really tough pill to swallow to go to a state where you won't be able to train in the entire spectrum of OB-GYN care. And as a result, many people are not coming to the South and to other restricted states when they otherwise had planned to.
Dr. Chandrasekaran, we just heard it firsthand from an OB-GYN intern who decided not to train in her home state. How do you expect the ban to impact recruitment and retention of OB-GYNs in Georgia?
Yes, thank you. That's a real important point. It's going to continue to negatively impact us. I think the hard part about this is you may not see that effect in 2 years, 3 years, 5 years. You have those of us that are here a little longer that might stay and be doing this. But then comes that, kind of the pipeline, right? Who's coming behind us? Who can we bring? Who can we train? How do we build up? That impact may not be seen again tomorrow or in a year. But in 5, 10 years, I think this is going to be a huge impact for a state that is already struggling.
Dr. Verma, how about retention? We've been focused on recruitment. Retention of an OB-GYN workforce in Georgia, now facing potential criminal prosecution for providing health care.
Absolutely. I think that some physicians in practice are thinking about leaving. I think a lot of physicians, right, this is their home, this is their community. They have houses here, they have families here, their kids are in school, and they aren't able to leave. But people are also, I've talked to folks that are retiring early or that are limiting their scope of practice. And that, in addition to doctors leaving the state completely, limits patients' abilities to get care. And so we're seeing all of these things combined affecting our workforce. As someone who mentors medical students and residents, I've had many people in the same situation where they say, should I stay in Georgia for residency? This is my home, this is my community. And I tell my mentees, I don't think you can get the same level of training in abortion care anymore as you used to. Like, I think, if I was making the decision now, I would leave, get the training, and potentially come back. But also that's unclear, right? Like, it's a scary environment to practice in.
And I should note that was a 10% reduction in residency applications across all specialties. Dr. Panicam, why did you want to be a doctor?
I wanted to be a doctor in part because of my experiences growing up here in Georgia and seeing people not being able to access healthcare, especially in rural communities. I studied public health in undergrad, and I found medicine as an extension of that. Doctors have an incredible platform to educate, to take care of people, to directly change the course of a community. And that's the reason I decided to go through the long process of applying to medical school and complete training. I've already been in this for about 10 years, and I have at least 4 more to go. And I would do it all over again. But I think what is challenging at this point is that we are not actually able to provide high quality care, evidence-based medicine to a lot of our patients And, in regards to what you had said earlier about how this might affect physician retention, we know that a lot of doctors stay to practice in the same state where they completed their training. This is well documented. And so if you are failing to attract physicians to come and train in your state, you are also failing to potentially fill many supervising physician slots in a handful of years. This is something, as Dr. Verma had mentioned and Dr. Chandrasekharan, it takes several years to see the effects, but it will come in time, and we're already starting to see some of these effects now.
And you wanted to help people. You entered this field. You've worked so hard to get these qualifications. You haven't been able to come and train in your home state. How does it make you feel as a young doctor to know that Georgia women are being forced to endure pain, risk of hemorrhage, risk of sepsis, as you laid out, that doctors in the exam room across from them have to look in their eyes and tell them that they face serious and uncertain risk of potentially fatal complications, but that the doctor's hands are tied by politicians? How does it make you feel to know that that is the situation facing physicians and patients in your state?
It is deeply demoralizing. Personally, I feel very guilty for not coming back. This is my community. I've always wanted to come back, and I feel like I've failed a lot of people as a result. I hope to come back one day, but I think that it's difficult without changes to the existing laws here. We want to do the right thing by our patients. Physicians work really hard and train for a very long time so that for every single person that walks through the door, we can counsel them appropriately. We can take their medical history into account. We can take their social circumstances into account and offer them the best choice for them. And by restricting abortion access and also by restricting training in abortion as a result, you are stripping that away from thousands of physicians practicing in restricted states. And it causes a lot of distress. It is something that keeps a lot of us up at night, and it's a leading reason why I think people decide to leave. It's hard to go to work every day and realize you're not offering your patients the level of care that you would expect to, that you would hold yourself to if you could. And the emotional consequences of all of this, I think, should not be taken lightly as well.
Thank you, Dr. Panakam. Final question for each of you, beginning with you, please, Dr. Verma. What do you think lawmakers should know about the impact of abortion bans like Georgia's extreme 6-week abortion ban?
For that question and for this hearing to bring attention to this issue, I think we as doctors are here trying to provide the care that we can to our patients. We are trying to get people in quickly within that often impossible 6-week timeline. We are trying to do whatever care we can. We're trying to get patients out of state when we can't provide them care here. And my colleagues and I, we're going to continue to do what we can, but the law has to change. It is limiting practice. It is hurting people. I get that abortion is complicated for a lot of people, and it's okay to feel that complexity and to also recognize that people are the experts in their own lives and should be able to make these decisions about their healthcare and their lives. And those things can exist together. There's so many reasons why people need abortions, and we are just in a terrible environment where we are trying to do what we can. We will keep trying to do what we can to support our patients. But as you've heard, it is an incredibly difficult environment and people are struggling, and the laws have to change. We have to get to the polls. We have to do what we can to change the laws.
Thank you, Dr. Verma. Dr. Chandrasekharan.
Thank you for that question. And again, thank you for this hearing and bringing attention to this. Of course, I echo what Dr. Verma said, but I want to add to that. I think, again, biology, human systems, a pregnancy, literally all the physiologic changes, a maternal body and a new being, a fetal being growing inside that body does to your body is not a machine. It's not black and white. It varies. And putting laws on a system that is extremely volatile and changeable and not identifiable as yes, no, black, white, this is it, is only going to lead to tragedy. And so this is not a situation where law can cover all the factors and the facets that we need to cover. That's why this is medicine and it's not law.
Dr. Panican?
I think I want to end simply by saying abortion is healthcare, and healthcare should be determined by doctors, not by legislators. There is a body of evidence that we follow, decades of research, of advocacy that have gone into why we think the way we do, why we offer certain procedures at certain times and not in other scenarios. And I think it is incredibly concerning that people without medical knowledge are now restricting our ability to provide evidence-based care. They're not speaking from a place of knowledge. And as a result, real people are affected, real people are getting sick, real people are having unwanted pregnancies, and real people are dying. And in order for all of this to change, we as Georgians and as, all residents in this country have to make it known that this is not something we will stand for. This is not acceptable, and that we should leave reproductive health care in the hands of physicians who have worked very hard and very long to achieve the level of knowledge needed to make those decisions.
Thank you, Dr. Panican. Well, I want to thank each of you for not just participating in today's hearing, but also for dedicating your careers to the health of your pregnant patients. And I have a sense of just how hard you've worked and how many extraordinarily long call shifts you've endured and how many 3 a.m. trips to the hospital to ensure that a laboring patient has a safe delivery you've made, and just how much of your lives you've invested in helping people. And on behalf of all Georgians, I'm extremely grateful to you, and grateful to you for lending your expertise today, because as I said at the opening of the hearing, there's a lot of political voices weighing in on this issue. The public needs to hear from the doctors who are providing care every day what this is really doing to pregnant women in Georgia. And we've heard extremely concerning reports today from leading OB-GYNs in Georgia and a resident who was deterred from coming to practice in her home state because of this extreme abortion ban. We've heard about women who struggle to get the health care they need at critical moments when their health's at risk, when they're experiencing a miscarriage and turned away from the doctor, about extremely worrying and high-risk medical scenarios that haven't yet reached some vague state of sufficient emergency, according to politicians who haven't practiced a day of medicine in their life. And we've heard about how Georgia's law is driving doctors out of our state when we already face a dire shortage of OB-GYNs that for years has been negatively impacting the health and lives of women in Georgia, including worsening the access to prenatal care in our state. So I'm grateful to all of you for illustrating what this really means for healthcare providers and for your patients. I would note for you and for members of the public that the hearing record will remain open for 1 week for statements to be submitted into the record. We welcome contributions from the public. Questions for the record for our witnesses may be submitted by other senators by 5 p.m. on Tuesday, July 30th. I want to restate my gratitude to Mayor Garrett and the city of Decatur for hosting us today. It's great to be in Decatur, and thank you again, and the hearing is adjourned.